We are standing on the right side of the cadaver, and if we note that the abdomen has been opened by a midline incision to expose or show the visceral disposition. So here see the parietal peritoneum. You can see the parietal peritoneum here, and what we can see is we have exposed the abdomen. Let's see how the viscera are arranged. Now this is the interior of the anterior abdominal wall. From here we can see the falciform ligament that is going and attaching, or you can see the bilaminar falciform ligament attached on the liver. Alright, this is the falciform ligament, this one. This is the free margin of the falciform ligament, and on its free margin we have the ligamentum teres hepatis. The ligamentum teres hepatis. Now what we have, see the upper end of the falciform ligament, the bilayer, they are reflecting on the undersurface of the diaphragm, and here also it is getting reflected as the the right triangular ligament, and on the left lobe the left triangular ligament that we can see later. If you come to the lower part, so this is the umbilicus. So this ligamentum teres hepatis was coming from the umbilicus up to the fissure of the liver. Now if you see on the inner aspect in the lower part of the anterior abdominal wall, on the midline we see the going right up to the umbilicus, starting from the apex of the urinary bladder. This is the ligament. This is basically the obliterated urachus, which forms the median umbilical ligament. Just lateral to that we have another, this you can see this is the obliterated umbilical artery. This is one of the obliterated umbilical arteries. This is the medial umbilical ligament, and lateral to that you have the lateral umbilical ligament, which is a fold of peritoneum covering the inferior epigastric vessels. If you see the disposition of viscera as we open, this is the greater omentum. The greater omentum is initially, you can see this is the liver. Below this is the stomach. This is the greater curvature of the stomach, and from here you can see the policeman of the abdomen hanging like an apron. This is the greater omentum. As it comes down, it takes into its folds the transverse colon and forms the transverse mesocolon over here. Alright, and from the transverse mesocolon is basically suspending the transverse colon from the posterior abdominal wall. If we see the lesser curvature of the stomach, here is the lesser omentum. Alright, here you can see the lesser omentum. Here attached is the lesser omentum, and behind the stomach is the lesser sac. So more or less whatever we can see here is the part of the greater sac, and behind the stomach lies the lesser sac or the omental bursa. And to enter into that, we have to go through the communication between the greater sac and the lesser sac behind the stomach is this epiploic foramen. See, this is the epiploic foramen. The epiploic foramen, if I introduce, goes behind, this forceps goes behind the stomach in the lesser sac. The epiploic foramen, if you can see, bounded anteriorly by the free margin of the lesser omentum, and it contains the structures at the porta hepatis. Below it is the common hepatic artery, behind is the inferior vena cava, and above superiorly is the caudate lobe, or rather the caudate process of the caudate lobe here. Alright, this one. So now if I lift this greater omentum, we can see how the lesser or the smaller intestine are coiled up and hanging by the mesentery. See, these are the coils of jejunum and ileum. This is the mesentery, and the mesentery, it attaches the, if I reflect this on the right side, the whole of it, we can see that the mesentery is hanging all the small intestine from the posterior abdominal wall by an attachment which is known as the root of the mesentery. Anything below this is the infracolic compartment, and anything above this is the supracolic compartment. Now if you move laterally to the left side, this is the descending colon, and the descending colon is lying in a gutter-like area which is known as the left paracolic gutter, and the descending colon is dividing the left paracolic gutter into lateral and medial parts. Now if you come to the right side, you will see As you can see, this is the small intestine. The jejunum is the initial part, then the ileum. From the ileum then converges at the ileocecal junction and joins with the continues as the cecum. This is the cecal sac. And if you go to the inferior part, here we can see the appendix, and the appendix is suspended by a mesentery, which is the mesoappendix. Then the cecum continues above as the ascending colon. The ascending colon lies in the right paracolic gutter, as we can see here. Then it bends to the right to form the transverse colon. This bend is known as the hepatic flexure or the right colic flexure, and due to its closeness with the gallbladder, here it has become stained green. It is of course post-mortem staining. Then the transverse colon, it continues and it again bends and bends at the left colic flexure and forms the descending colon, continues as the descending colon. This is also known as the splenic flexure. Now I have come to the left side of the cadaver, and we can, if we retract everything, try and retract everything to the right side, then we can see a retroperitoneal structure here. This is the spleen. The retroperitoneal structure here is the spleen. Just below the spleen, if we go just below the spleen, here we see there is one ligament here, a fold of peritoneum, which is acting as a chair of the spleen. This is the phrenico-colic ligament from the diaphragm to the left hepatic flexure, the left colic flexure or the splenic flexure. This is like the chair to the spleen. Presence of this basically divides the hepatic recesses on the left side and the left paracolic gutter. Also, it prevents, when in case of splenomegaly, it prevents the spleen from enlarging directly downwards towards the left iliac fossa. The spleen obligatorily enlarges towards the umbilicus and towards the right iliac fossa. Coming back to the right side of the body, you see this is the diaphragm. The diaphragm and the spaces between the liver, this all forms, and around the liver, these spaces form the recesses around the liver, suprahepatic, infrahepatic, of which the right sided space or recess, the hepatorenal pouch of Morrison, is the most dependent space when the patient is supine. This, and the hepatorenal pouch of Morrison, it communicates with the lesser sac through the epiploic foramen. Now we will remove the